started. So we are going to jump to, let's see, that's 1, 2, 3, 4, 5, 6, 7, 8. So we start on page 9 of your lab manual. It should be with the tongue. I don't know if you can see it, the tongue pictures. Okay. And we start with basically the beginning of the system. Okay, let me get this closer. All right. Which is the oral cavity. Woo! This thing falls. All right, so we're starting with the mouth. Let me see if I can get it. Feels like there's a bad glare. I can't really tell if it's clear or not. But we're going to start with the mouth. Okay, so, oh my Lord, I am falling apart over here. All right. Where? There it is. Okay. All right. Okay, so the digestive tract is going to be the alimentary canal. So mouth. So on here, it kind of is the long tube, mouth to the anus. All right, and everything that's in this tube is going to touch epithelial tissue. So by definition, everything in this tube, even though it's inside of you, it's kind of like in a tunnel, and it's really running through this tunnel separated outside of the body. Okay, and as it goes through this tube, you are going to see areas of mechanical breakdown. So mechanically pressing, pulling, tearing, shearing. All right, and you're going to see areas of chemical breakdown. All right, now the tube is on most of the locations going to have 4 histological layers. All right, and the 4 histological layers are going to be part of almost every, when we get to every organ, you're going to have questions, maybe 1 or 2 about what is this histological layer? What is this feature of this histological layer? What are some of the specific tissues in the histological layer? Versus then what is this feature? What is this blah, blah, blah? What is the cell, or what is important coming on or happening here? All right. And this in your lab manual is trying to show you it has the esophagus, the stomach, small, and then large intestine. So the 4 major parts of the tube are represented on here. All right. And those histological layers are going to always usually be the innermost layer is where that epithelial lining and some of the areolar connective tissue is. And then there, in many cases, and it's shown in this model, there will be a little bit of smooth muscle that kind of forms the barrier of where that innermost layer ends and the next layer begins. All right, and so that layer, that innermost layer that's always going to contain the epithelial tissue touching the food, interacting with the food, is going to be your mucosa layer. Okay, and then the next layer is going to be more of like the dermis of the skin. It's a very dense, irregular, connective tissue rich area. It's where the bigger blood vessels, the Peyer's patches, the malts, the lymphatic system vessels, the nerves are going to be taking most of their, residence. And so in this model, it's this kind of gray area. That is going to be the submucosa because it's underneath. Right? Then you're going to get to your smooth muscle-rich layers, and your smooth muscle-rich layers are going to be your Muscularis Externa. And the reason why it's the external layer is because these smooth muscle layers, part of the mucosa, are known as a Muscularis mucosa, and they're part of the mucosa layer. So this layer is known as the Muscularis Externa because it's more external. And then the outer layer, it could be one of 2 things. And because we have some exceptions to the rule, these are always good potential questions to ask. The outermost layer in places like the esophagus and places like the rectum are going to be known as an adventitia. So they are going to be like the outside of the liver, the outside of the kidneys, the outside of lymph nodes, the outside of organs. They're like a capsule. And they help keep keep the tube in its spot, anchor the tube. All right. Everywhere else, so around the stomach, around the majority of the small intestines and the large intestines, it's in the abdominal pelvic cavity. So if you go back to chapter 1, the outermost layer is going to be the visceral peritoneal membrane. So it's going to be part of that system where you have simple squamous epithelium and underlying areolar connective tissue. And then there's a little bit of space and fluid, and then there'll be simple squamous epithelium and more areolar connective tissue. That's going to be the parietal membrane. And then that space that's created between them is going to be the peritoneal cavity. All right. And the peritoneal cavity is going to be a little different than what it was in the lungs and the heart, because this cavity is going to have to, if we look at this, it needs to wrap around this entity, and then it needs to wrap around these individual areas. So think of it like ruffles on a dress. You're going to create these ruffles, and they're going to wrap around parts and pieces of the organ, so they have some like independence to be able to move, and their moving is not going to necessarily affect the organ around them, even if it's the same organ. Okay? And then where the ruffles like need to go to the next organ, it'll kind of have a little elongation, and then it'll ruffle around and wrap around the next organ. All right. So the peritoneum is a little different from the parietal membranes, the pericardial membranes and the pleural membranes. Okay. All right. So as you go through each part of the alimentary canal, we're going to try to talk about what is going on histologically as one part. What are the layers? What are the features? And then we'll talk about what are then the other features and anatomical landmarks and things to know about. Okay. Now, the mouth and most of the pharynx isn't really a tube per se. So you'll have the mucosa layer. You'll have the submucosa layer. You'll maybe have a little bit of the muscle layer, the Muscularis Externa, but then the rest of it will kind of merge into the cartilage and the bone and the other pieces and parts that are part of the skull or the back of the throat and the neck. All right. Okay. Three things located part of the system, not on the alimentary canal, are going to be the pancreas. So the pancreas is part of the system in that it pushes enzymes and secretions into the alimentary canal, but the pancreas itself is not part of the tube. The liver, again, the liver is going to get all the blood supply, all the lymphatics fluid from the digestive system, and it's going to have some influence to secrete things into the digestive system using the gallbladder and the bile system. But the liver is technically not a part of the tube. All right. And then the gallbladder is another system that, again, helps take the secretions from the liver, it stores them, and then helps make them available to push in with the pancreatic secretions, so you can get more secretions into the small intestines, especially to help chemically break down more things with more enzymes. Okay, so be aware that you have three pieces that are technically not on the alimentary canal. So if you were going through like a tour of the house, these would be like the shed, you know, the swimming pool. You don't actually walk through the swimming pool when you're touring a house, you know. So, but they're important pieces and parts of the system. Okay, so digestive anatomy, starting with the oral cavity, also known as the buccal cavity. So just like we did with the nasal, what is the anterior border? The anterior border is your lips. Again, another name for your lips are your labias, okay? Then you have a little bit of space between the lips and the teeth. That tends to be that more oral vestibule, that space. And then the cheeks are going to be, again, part of like the anterior, maybe even the side. They are also your buccal space a little bit, okay? The posterior is going to be this opening kind of where the uvula and the arches are. So that's your fauces, all right? And then the arches are going to be the most anterior is your palatal glossial arch. And then the most, I think it's correct, the most posterior is the one closest to the pharyngeal, so it's that palatal pharyngeal. Okay, you do have the palatal tonsils kind of sitting back there, and then again, the palate, the soft palate does kind of form that fold, and that is your uvula. All right. The top border is the hard and soft palate, and the hard palate comes from being a bone, the soft being some of the connective tissue. And again, if that bone does not form correctly, that's why some people have to have surgically like that opening closed, so food and air are not pushing into and out of between the oral and the nasal cavity. All right. The inferior border is your tongue. Okay. And your tongue, as it shows in the pictures from chapter 17. So those images in your lab manual come from chapter 17. Chapter 17 was where we went over taste, the gestation taste. And so they had the pictures of the tongue. All right. So again, the very front portion of your tongue is known as your, I think that's the oral portion of your tongue. The posterior, the root area, is also known as your pharyngeal portion. You have the top of the tongue is superior. You have the dorsum. You have and then on there you have all these little papillae, which are going to, again, lingual papillae, filiform papillae, fungiform papillae, circumvallate papillae. They're where your taste buds are hanging out. All right. And what ties the tongue at the bottom is going to be your lingual frenulum. And remember that for the frenulum, that is how we get some of the mobility of the tongue to be able to move it for speech. So when the frenulum is too thick, or when it comes too anterior and you don't have a lot of tongue to work with in the front, sometimes people have a hard time making certain sounds for certain speech. So they might do a surgery where they cut that lingual frenulum, give it more space. The other thing you might see is people on purpose put a piercing in there, and they have something that usually sits under their tongue in the frenulum, not at the very front, but kind of in the center. And so they have like a little barbell or something that used to be popular back in the day to pierce your frenulum. Okay. On the sides of the frenulum will be some of the ducts for the salivary glands. And so that's why when you pick your tongue up and you have your frenulum, usually it's very wet down there. And that's because that's where secretions for saliva are coming out of two of the saliva glands. All right. If you don't remember from your cranial nerves, there are different parts of the tongue innervated by different nerves. They're going to control the gross motor, the fine motor, and they're going to take some of the taste. And again, they're going to take some of the taste from water receptors, temperature receptors, texture receptors, and those are some of your general senses, right? And then there are receptors related to the special senses that are going to be sweet, sour, salty, and the other one, umami, I forget, but those, all right? The trigeminal nerve is a big one for your jaw and your teeth and your sensation of your lips and your face. But again, some of the taste is on the glossopharyngeal, if I remember, and your hypoglossal cranial nerves. That was why I made you learn them all last semester, although none of you took me last semester, or you took me a long time ago, so hopefully you remember all your cranial nerves. All right. For the model, so expect me to try to put landmarks on here, all right? Or from your lab manual, expect to see some of these pictures. Even this one with the, I need to put this down, all right? And this one that shows like the mouth opening for the tongue, for the arches, that could be something for some of the landmarks as well as the sagittal cut that shows you, your anterior, posterior, inferior landmarks as well. All right. We kind of assume most of the epithelial tissue in the mouth is stratified squamous, non-keratinized, because most of it's located near an opening. Most of it has to be pretty robust to, as it gets abrasions, as it gets hit and beat up on, it needs to have a few layers of protection. It is very wet in your mouth. So again, that's why it's non-keratinized. So there's not as much keratin in there as the skin, so it can stay wet and moist And again, we know there's a high rate of turnover because most of the time if we have sores in our mouth, they don't usually stick around for weeks like some of the sores or bumps or scrapes and tears in our skin. And some of that comes from being it's so wet and being there's so much rapid mitosis, the cells will, you know, multiply and replenish. Okay. The pharynx, again, as we talked about, is going to be behind the nasal. That's the nasal. Behind the mouth, that's the oral. And then as you get into this region where the larynx, the epiglottis is, that's that region. All right. And again, the pharynx is beginning to maybe be a mix of epithelial tissues. There are still some of like temperature receptors, texture receptors, stretch receptors, as well as, you know, different things for knowing the food is coming. You're not necessarily tasting food as much back there, but there could potentially still be some Caspian, you know, the ones for the peppers, Caspian receptors. There could be the ones for, again, water tasting a little bit back there. But for the most part, it's more general receptors, general sensory receptors. Okay. All right. Salivary glands. So salivary glands, remember the tonsils or 3 pairs, you get the little girl picture. The salivary glands, you have a model. All right. Salivary glands, this is the type of, these are again epithelial. They're tending to be, I don't remember if they're like stratified cuboidal or something else, but these as epithelial tissues, remember they can be turned very cancerous like pancreas, and they are a nasty cancer. And a fun fact, the guy who started Popeyes, and he was like this big chef in New Orleans area, he also started another big series of restaurants called Copeland's because his name was John Copeland. He died of salivary cancer. Salivary cancers are a lot like breast cancers. They have some estrogen links to them. They are like some estrogen, like some breast cancers. They are not responsive to meds. That's why they're nasty. And then visibly, when you have cancers in this area, it looks nasty because, you know, it starts to eat away at your face. All right. So the big gland back here, that is the parotid. And then you have the big one down here is the submandibular, and then you have your lingual. All right. And in the lecture part, it talks about like saliva is going to give you a lysosome, so a type of enzyme to try to kill some bacteria and pathogens in food and drink. It's going to produce, potentially there might be a little bit of antibodies that get secreted in there from some cells in and around the area. And then from B cells that are, again, putting their antibodies in the interstitial fluid, it can get picked up by here and then put in there. These cells are going to also make the first enzyme for chemical digestion, and then it's going to be salivary amylase. Now, salivary amylase, if we have 3 big categories of food, we have proteins, carbs, and fats. Salivary amylase is going to start breaking down complex carbohydrates. They are known as polysaccharides. They are going to break them down to a disaccharide, maltose. Now, you still need maltose to become the monosaccharide, glucose and fructose, because it's 2 of those, I think, combined together, or 2 glucoses together. So you still need another bond broken, but salivary amylase starts at least to break up glycogen. It starts to break up the big complex carbohydrates we tend to get mostly from animal products in the mouth. Now, you might also have a little bit of salivary lipase. And so some of your lipase enzyme is going to start the chemical breakdown of fat. So triglycerides can be broken into fatty acids and glycerol. So technically, out of the 3 big groups of food, you start 2 of them in the mouth chemically breaking down. All of the food will then undergo mechanical digestion with your teeth and with your tongue. Okay. All right. This big duct up here is the parotid duct. And again, down here where it connects and ends up by that lingual frenulum, that'll be your submandibular duct. Okay. All right. So There will be one of these on your lab test. And again, do not get these confused with the tonsils. Somebody always does it. All right, moving to the teeth. And you will have at least 3 pictures of teeth. And they're the 3 represented on this board. Okay? So, first question is going to be this. Which group of teeth are which? So the first 2, technically 2 top, 2 bottom, and then again, the first ones we normally get in life, these are your incisors, all right? Then you get usually a pair each on top and bottom. Again, the Dracula teeth or the canine, the dog, the saber tooth, you know, the ones we think of. These are those. And then 4, 5, all right, are going to tend to be our bicuspids because they might start to have 2 roots, all right, or our premolars, okay? And then the back teeth, your wisdom teeth, which some of you might still be having issues with or having to get removed because you're still young enough. These are your molars, and they might tend to have 3 roots, okay? These are the ones when you get braces, they usually anchor onto to like pull the front of the teeth forward, back, up, down, move them around. All right. Okay. Again, on the teeth picture down here, so the ones up front are your incisors. Usually number 3 is going to be your canine. Then you get your bicuspids or premolars, and then you get your molars. And those of you going into dental, of course, you'll learn that every tooth has a number. And then part of your job as the dental tech or the dental assistant, the dental person, is you have to clean them. But when the dentist comes in and does a check on them, you have to fill out the report and you have to know which tooth he's talking about when he says 4 is a 2, 5 is a, you know, like he grades them on a scale. I think it's like 0 to 4 or something. Okay. All right, remember these teeth are sitting in your maxillary bone and your mandible in the pocket that's known as alveolus, okay? All right, so know your teeth. And again, you're gonna only see adult teeth. You won't normally see baby teeth, all right? And you're gonna see the teeth as presented as a picture from here. So learn them on here. Now, moving to this picture is going to provide us the way to do the teeth histologically as well as for features. Okay? So, pieces of the teeth, the exposed part of the teeth. So the tooth, everything exposed in your mouth to the air that could potentially touch or interact with food and drink is known as the crown. The neck is going to be the part of the tooth where it's interacting potentially with the gum. And then everything that's bone to bone is going to be the root. Okay, so those are features of the teeth. All right. Histological layers are going to be the white outer part of the tooth is the enamel. The yellow kind of bone cell, you know, spongy bone, trabecular bone part is going to be your dentin. And then the inside cavity is your pulp cavity. All right. And then the part of the tooth that pushes into the alveolus little cavity structure, that's the root. All right. And anywhere you have bone touching bone, there's usually going to be a periodontal ligament. Okay. There will also be some cementum, which is going to also reinforce the periodontal ligament. Because again, ligaments might have a little give and we don't want our teeth to have give. So cementum, like cement, is going to help solidify them bone to bone stuck in their chambers. All right. The gums are known as your gingiva. So anytime you have a inflammation, and again, they will have some epithelial part, then they're going to have some connective tissue part. They can have a lot of white blood cells and stuff in here. That is any inflammation in there is gingivitis. All right. And then the hole in the tooth. So the tooth is a bone. The hole in the tooth that allows blood vessels, nerves, lymphatic vessels in and out to make their way to the pulp cavity is going to be known as the apical foramen. So remember, holes in bones are named foramen. Okay? The little hole at the bottom. Okay? Now, if you look, the enamel, so if you go and drink a lot of soda, drink a lot of coffee, a lot of times the food and the acidity of your food wears away your enamel. Your dentin, again, is one of the quickest bones to degrade with age and with malnutrition. So if you think about it, you are very, very, very close to having nerves and blood vessels and lymphatic vessels exposed to the outside environment to an entry point to where a lot of pathogens do try to come in. So one of the reasons with pregnancy, it's like part of a pregnancy checklist. Before you get pregnant or in the early stages of your pregnancy, you have to go visit the dentist. And if you have any potential issues with your teeth, you try to get them corrected then, because if you start to have issues with cavities, holes, breaks, tears, and bacteria and fungus and things are getting into your blood system, it can very quickly cause an infection in the body. And if you're carrying a baby, it'll potentially cause problems with that. So it's one of these little things you don't realize, but your tooth health is very, very important to have well taken care of before you get pregnant. All right. And for some people who have very long-term like issues with, they just can't seem to get rid of some type of infection and some type of, they just seem to be sickly. Sometimes if you look at their teeth health, that is part of the reason why they never can get well, is because they don't have good tooth and teeth to prevent more pathogens from constantly getting into their system. All right. The joke is, in our Western world, most of us have grown up with, we go to the dentist pretty regularly, but in other countries, the emphasis of paying for dental health and having dental health is a luxury. It's not a, like a normal necessity of life. And so when I was living in Japan, one of the jokes was you'd see these beautiful Japanese girls and they would come and try to talk to the guys that we worked with, the GIs. And they were all beautiful, and then they opened their mouth. And the minute they opened their mouth, you could tell like they hadn't had dental care probably throughout their life, because they hadn't had braces, maybe had some yellow, black teeth, just, dental issues. And one of the girls, she wanted to become a TV person. And the first thing they told her, before you can get on TV, you have to have your teeth fixed. So she was working on her English skills with my roommate at the time, who taught English for Japanese people, like a conversational, interactive English, and just for fun for her. But she was like, the whole 2 years we were there, this girl was getting her teeth done so she could then work in television. So it's weird. Other jokes are typically the British don't always have pretty teeth. A guy has a cute British accent, then he opens his mouth and you're like, ooh. So again, we don't realize, but tooth health is important for lots of things, and it's very much a perception. In some countries, it shows how much wealth you have because you were able to take care of your teeth. Okay, so again, histologically, you would look at, if you're looking at the numbers, 19 is the enamel, 20 is the dentin, and 21 is the pulp cavity. If you're looking at features, the exposed part is number 17, that's the crown. 25 is the gingiva, so this little area here would be the neck, and then anything bone to bone would be considered the root, and again, there's 18 for that. Okay, I guess it's down here, I can't see that number, I think it's 24 would be where the apical foramen is, and then 26 is kind of representing your, again, ligamentum, what is it? Periodontal ligament. All right. And then maybe even 23 could also represent a little bit of the cementum. Okay. When you get, again, a crown put on, they put a little fancy cover, and then that's trying to help prevent the tooth from dying. And then when the tooth dies, they drill in, they deaden and kill your root, and then then they try to fill all of the inside with, you know, material to just keep the tooth there physically, so they don't have to pull it. You know, so when you start getting into the higher levels of dental procedures, crowns are put on first. Then normally, if the tooth is still inside dying and full of bacteria and cavity and everything, infection, then they go in and kill the root, kill the blood vessels, seal everything, and then hope the tooth will remain. And then eventually, if that just still doesn't work, they pull it out, and then you get fake ones, okay? All right. All of my wannabe dental people, you usually love this lab exam because there's about 10 questions, just from 10 to 12 questions just from that. All right, so that should get us through the first 2 pages and half of the next page. All right, next thing we get to, you've gotten through the pharynx, so now we're through, let me get this properly. Remember this guy? So here's the trachea. Remember, right behind him is the esophagus, and then eventually when the trachea forks away, the esophagus and the descending aorta are together, and then they're pushing through that, that area of the diaphragm to get to the lower regions, okay? There is no, for the outside, there is no serosa / no visceral peritoneum, because this is not in the abdominal pelvic area, right? So the way that the esophagus is attached and stays with the trachea, the way the esophagus and the aorta are connected to each other, are through basically the adventitia, the dense, irregular connective tissue that forms the tunica externa and the adventitia. And they stay together, so it's a lot harder to kink, to twist, to clog them, and prevent blood flow and food movement. Okay? All right. Now, again, looking at the esophagus, the first part, so the top part of this model, the innermost layer is going to have stratified squamous epithelium, areolar connective tissue, and then there should be a little bit of smooth muscle that's known as the muscularis mucosa. That 3 kind of components are going to form the esophagus. The innermost mucosa layer, then you'll have submucosa, then you'll have Muscularis Externa, and then you'll have the adventitia. Now, if you go back and look earlier at the trachea picture, and if you look at this histology picture cut in transection, the esophagus, the innermost mucosa layer, is going to push in. So it's not a hollow tube like the trachea. So if I go back to page 1, 2, 3, 4, page 4, remember this picture? See how the trachea has a lot of openness to its lumen for air to go in and out? And the esophagus right behind it doesn't. Okay? So that epithelium, that mucosa, is going to push in. Right? And the other thing that's going to be part of the esophagus is you can kind of see it right here. See this guy? If you remember, it kind of looks like a sweat gland. So it's a gland that's going to push in and just keep this esophagus moist. So if the saliva and the breakdown of food in your mouth is going to push it past the uvula, push it into the pharynx, you're going to continue to push it in. The top of the esophagus is going to be known as your first sphincter. That is your upper esophageal sphincter. And then when you've let the food in, these little kind of modified sweat glands are going to continue to produce liquid in here, so I can continue to keep the esophagus wet. So if the bolus is a little drier than I would like, because maybe my saliva isn't quite robust enough, I can keep it sliding down. Okay? Now, there's not a lot of push in, so in this picture here, it shows a few holes. Again, those holes just would represent some of these glands pushing fluid in to help just keep the inside of the esophagus moist. If you've ever tried to swallow dry, like a multivitamin, without water, because again, the inside of the esophagus is a lot of push in by the mucosa layer. Most of us has probably felt that vitamin go down every millimeter of the way, okay? And so again, there will be some stretch receptors. There will be some, again, reflexes to try to get the mucosa, muscularis mucosa to kind of constrict and dilate to let passageway through, as well as to get the Muscularis Externa going, so you can try to peristalsis, coordinate. So everybody's tried to get the last little bit of toothpaste out, and you kind of squeeze and you try to like push it so it goes all the way to the tip. So you try to do that in your esophagus too. That coordinated movement by your Muscularis Externa is known as peristalsis. Okay? All right. And your esophagus gets a lot of help when you're upright with gravity, but we spend a lot of time seated or laying down. And when we lay down at night, we're still swallowing, a lot of saliva being produced. So that's when the peristalsis is really important as well. Because if you don't have gravity helping, you need to just kind of keep that toothpaste moving in the right direction. Okay, so you have the first sphincter at the esophagus. At the bottom of the esophagus, you're going to have your second sphincter. That's going to be known as your lower esophageal sphincter. It is going to connect to your stomach. All right, and your stomach is now officially inside your abdominal pelvic cavity underneath the diaphragm. So your stomach is going to have mucosa, submucosa, muscularis, and the outside will start to be the serosa layer, which is your simple squamous epithelium, areolar connective tissue, which is your visceral peritoneal membrane. Okay? All right, stomach. Now, while we're still on the histological layers, here's the model of the stomach. So the stomach's mucosa, so here's that muscularis mucosa. Here's a little areolar connective tissue. Here is your simple columnar cells, most of these purple and yellow cells, okay? It is going to have a few of them kind of pushing in and out, making a little bit of hills and valleys, but this whole thing of hills and valleys is stretchable. Okay, so the mucosa layer is going to have some stretchability, so that is why it's going to be known as rugae, the hills and valleys in the stomach. So when you look at, again, you open a stomach and you look at the hills and valleys, that's rugae, that's stretchable. All right, it's full of simple columnar cells. The simple columnar cells are going to have some secretions sitting on top known as your gastric juices. Those gastric juices are going to be, here's a little duct. Think of it as like a little doorway. And then here's a little tubing surrounded by more simple columnar cells. But these simple columnar cells are going to specialize in making secretions that get pushed up into these ducts and then pushed up here to sit in the lumen of the stomach. So these are known as your gastric glands, okay? And in your gastric glands, you're going to have chief cells, you're going to have P as in Papa, D as in dog, G as in God, different cells. They might have some different names, all right? And they are going to make different secretions, okay? And their secretions are going to be the gastric juices. All right, and we'll go over some of that tomorrow. Okay, so that's the mucosa. Then you have the submucosa layer. The submucosa layer is going to be where we have lots of nerves, big blood vessels, those any kind of gatherings of lymphatic system things. All right. And some of the nerves are going to be connected to receptors that are sitting up and around this areolar connective tissue of the mucosa that are sensitive to pH. So if the stomach pH gets too high, it's not acidic enough, they can quickly do a little reflex, Some of the nerves in here will say, whew, the pH is getting close to 6. Drive some of these cells to make more hydrogen and chloride, make the pH come back down to 2 to 3. Some of the cells in here are going to be tied to some receptors that are sensitive to stretch. So as you eat and your stomach stretches open, those stretch receptors will come to some of the nerves in here and go, we're stretching. We need to trigger the muscle here and here to contract so we can start mixing. Okay? Those nerves are going to be part of your enteric nervous system. The enteric nervous system is said to be your second nervous system. It is entirely in your digestive tract and it is cut off from the brain. So when your stomach starts mixing and doing reflexive things, it does not come into conscious awareness. So if you ate an hour ago, is there food in your stomach? Yes. Is your stomach mixing it? Is your stomach releasing more acid or base or moving it around? Is it trying to put more water in there if it needs more fluid? Yeah, it's doing all those things. Are you aware of it? No, because this nervous system is not talking to this nervous system. So that's the enteric nervous system. It was mentioned like 3 sentences in chapter 16, and that was it. And you're going to see more of it in chapter 24. Question?
So I know how you just said that. So even when, like, I thought it's digested, that it's still bringing, like, I guess, the food and water.
So some of the hormones are going to your brain to say, stop eating, we're getting full, or eat, we're getting empty. But the actual stomach saying, okay, I'm going to contract, relax, I'm going to swirl and twirl, I'm going to make more acid or not, that is not handled in the brain. That's handled locally. And it's not even going to your spinal cord. So that's kind of why your digestive system could kind of keep working without the brain being around and alive and well, because it's kind of its own little, it's a lot of little reflexes, okay, that kind of triggers some things to happen based upon, hey, pH went up, let's make it more acidic. Stretch is happening, let's mix, let's grind, food must be in there, okay? All right, and then in the stomach, you're gonna have 3 layers of muscle. So most places you have 2. You have what goes around and then what goes the length. So you can make tubes longer and shorter. You can make tubes smaller or bigger. In the stomach, you also have an oblique layer, so you can kind of wring it out a little bit too. Okay? And then the outermost layer of the stomach is going to be, again, simple squamous epithelium, a little areolar connective tissue. It's the visceral peritoneal membrane. If you look in this model, it shows you. So you see there's that brown cell layer of simple squamous cells, and then there's a little bit of areolar connective tissue and some space for blood vessels. There it is. That's the visceral peritoneal membrane. Where this, if this gray was the cavity, I would expect another brown little simple squamous layer, another little bit of areolar connective tissue, and this would then be the peritoneal cavity with that serous fluid in it. Okay? And again, when it comes off the stomach, because it kind of, think of this as the ruffle, it encased it. When it comes off the stomach, it comes like 2 sheets again together, and then it'll go and wrap around the large intestines. Then it'll go and wrap around pieces of the small intestines. So it'll come off the stomach, all right? And then it'll go and wrap around here, and then it'll go and wrap around here, and so on. And so, again, if the 2 sheets are the visceral and the parietal membrane, 2 long sheets, they kind of go and wrap around and go and wrap around. So they're not like, it's not like a big sack and all these organs are inside. Each individual organ and piece of the organ is individually wrapped, but then it's kind of a little bit of a continuous membrane together, wrap around, together. So I like to think of it as it makes ruffles and wraps around things. Okay. All right. Landmarks of the stomach. All right. So your stomach sits left side like this. Right here, sometimes your heart apex could hit. So this is known as the cardiac area. So sometimes the lower esophageal sphincter is known as your cardiac sphincter. This is the sphincter. If it doesn't close all the way, it causes regurgitation and the acid is backsplashing into your esophagus, and people call that GERD. In babies that throw up and spit up a lot, that can cause them to be really irritable. And some people who think they're having a heart attack, it isn't a heart attack, it's just GERD, backsplash, all right? And some people who are having a heart attack, because they don't realize it's GERD, they start taking lots of Tums because they think the pain, which is their heart attack, not getting enough blood to the apex and the left ventricle, it radiates this feeling of pain in the stomach because it's all local area. So there's not a lot of good pain receptors like in our skin. There might be a few pain receptors, and they're going to respond to all of the issues that happen in this area. Okay, so GERD and heart attacks, it's all real close together. There's a few pain receptors that are going to respond and tell you pain is happening here, but they're not going to be specific to this is heart pain, this is esophageal pain, this is stomach pain. Okay, and for women, more likely than not, they seem to have stomach pain, and that's how they know they have that's their heart attack symptom. Okay, so again, these receptors here, it might be actually the heart's in pain, but it's going to radiate to the brain from receptors that are more likely to be associated with this, the stomach. Okay, now if you draw an imaginary line where the lower esophageal or the cardiac sphincter should close and everything would gravity help fall down, the area above that, that's known as your fundus. Okay, and what's cool about the gastric, and this is in one of your slides, the gastric glands here, they are going to have more cells to make the hormones obistatin and ghrelin. And ghrelin's been a lot in the news lately, like with leptin. It's one of these hormones that we know has a big role in telling your brain you're full or telling your brain you're empty. And so if you think about it, if food starts to accumulate all the way up here, you're probably really full. So you would want hormones up here to be sensitive to, we're really full, tell the brain to stop letting food in the mouth. Okay? Most of this part is the body, and most of the cells and the glands in the gastric glands here are going to be your typical chief cells, your typical G cells, the ones that are making, again, lots of hydrochloric acid and responding to the changes in acid, and they're going to be the ones responding to the hormone gastrin. Gastrin being the hormone that tells them food's in there, mix it up, and keep the acid flowing. Okay? When you get to this kind of curve and turn, this area where you're getting close to the exit door is your pyloric region. And once you get food in this region, and again, maybe it starts to be more empty of food, you would want to start telling the body again, start eating, but you also want to start telling the body, especially the small intestines, the next piece of the line, food's coming, prep up your bases, because the minute the food gets into the next step, we need to bring the pH back up to normal. So the food might enter and leave this area at a pH of 3 or 4, so that's super acidic. We need to get it back up to 7. So how are we going to do that? We're going to throw a bunch of bicarb in there, versus here, we keep the bicarb and we throw a bunch of acid in there. So remember that equation for carbonic acid? Carbon dioxide and water are combined to form hydrogens and bicarb. In the stomach, when you make hydrogens, you're going to stick them in the stomach. In the small intestines, when you make the hydrogens and the bicarb, you're going to stick the bicarb in the lumen. So the pyloric sphincter is kind of a good landmark for acid-base balance. If you have a pathogen that makes you throw up a lot, you are going to be, as soon as you put acid in, you lose it. So you make more acid and bicarb, you lose the acid. More acid and bicarb, you lose the acid. It's a place where if you have a pathogen that makes you throw up a lot, you could potentially make yourself metabolic alkalosis, because you're losing faster acid, and by making that acid, you're retaining all this base. If you have a pathogen that works behind the pyloric sphincter, where you put base in constantly to try to neutralize the acid, and so you have diarrhea, 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 one, you're going to get dehydrated. But the other side of that is you are potentially going to have metabolic acidosis, because every time you make a bicarb and an acid, you get rid of the bicarb, so what stays behind? Acid, acid, acid. All right, so in chapter 25, when they talk about what is a reason or a way you can end up with metabolic acidosis, something that makes you massive diarrhea for, long time, or how's a way to get metabolic alkalosis, something wrong with your stomach, and you're constantly throwing up, so the minute you make the hydrogen and the bicarb, you lose the hydrogen, but you keep accumulating the bicarb. Okay? All right, I think, okay, anterior surface, and then the greater omentum. So remember how I said the visceral and parietal peritoneum form ruffles? So the space of leaving the stomach to go wrap around the transverse and the part of the colon, and then eventually the small intestines, all right? This is gonna come off here, and it's gonna be known as your greater omentum, and it's also going to go in front a piece of it, so it's going to make a big kind of like covering in front of all of the small and large intestines, and it looks like an apron in your picture. And so that is known as the beer belly, the apron, the greater omentum. And in men, your testosterone tells you to put all of your fat storage initially here in this membrane, this visceral and parietal membrane, and all the adipocytes inside their areolar connective tissue. That is where it tells you to store your fat. So that's why guys, especially like guys in their 20s, 30s, you would think young men, but when they start to gain weight and fat, they start to have the beer belly, and then they still have the chicken legs and the chicken arms. Okay? So this is the greater omentum, the one that comes off here and would attach and play a little bit of holding in its spot and then helping to hold the liver in its spot. That's the lesser omentum. Okay, I think I got that. Okay, so some of the cells you're going to talk about in the different glands. And again, the glands in the pyloric region versus the fundus region versus the body are a little different. But we have parietal cells, we have G cells, we have chief cells, we have D as in delta, we have P as in papa. There was some different cells. So when you're reading chapter 14, that might be something you want to do, is list for the cells, what are some of the products they make? Okay. Now, one of the things I always hear about is intrinsic factor. It's so important, intrinsic factor. Yes, it's important later on that you absorb some vitamins because you have intrinsic factor in your stomach. But physiologically, great, you absorb some vitamins later on. The things that I find important are you're going to make hydrogen and chloride secretions, and that's going to help you chemically break down proteins, chemically break down some fats and some carbohydrates, some of their ionic bonds if they have them, some of their hydrogen bonds if they have them. You're going to denature things, right? You're also, for babies, you're going to have renin, and the renin here has 2 ends. So not the renin with 1 end from the kidneys, but 2. Renin is an enzyme that helps babies break down milk proteins. So it's an enzyme you make from these cells to help you break down as a baby milk proteins and fats, okay? And then gastrin is a big signaling molecule made in the stomach to keep kind of foods in the stomach. Let's keep the line moving. Let's keep food, like the food prep going. Let's keep the hydrochloric acid being made. Let's keep the secretions going because food is still in the stomach. Let's keep the mixer moving. All right, keep the muscles contracting. Okay, so as you look through, again, these groups of cells, you don't necessarily need to identify them in particular. You need to know that they are part of the glands, and some of them are going to be more popular in certain glands, like in the body, than in the fundus, than in the pyloric region. So, and then there will be some additional cells from lecture that you'll see that show up to make other things. And those other things are usually going to be the signaling molecules to start telling the brain or start telling the small intestines, hey, this is coming, or hey, stop eating or start eating. Okay. The only thing that's really absorbed in the stomach is alcohol and some vitamin drugs, you know, and like aspirin is absorbed in there. Most of what the stomach is for is chemical digestion and more mechanical mixing. Okay? The one other enzyme that gets added by the glands to the stomach is pepsinogen. Pepsinogen is its inactive form. When it gets into the pH-rich area, remember how fibrinogen got a little like cut, like a haircut, and then it became fibrin. So pepsinogen gets a little haircut and becomes pepsin. When it's pepsin, it is able to break peptide bonds. So it starts to break proteins, which we haven't quite yet started chemically to digest from the mouth or the esophagus. Then we start to break it down. So protein chemical digestion really starts in the stomach. Carbohydrates and fats had a little bit of an opportunity to get started in the mouth, but not protein. Protein starts in the stomach. Okay? All right. Moving to the small intestines, which is all of this. Your small intestines is going to have 3 key regions. The first region, if you pull your pancreas model, is this nice C around the pancreas. Okay? So this nice C-shaped part around the pancreas is the first part of your small intestines. It's called the duodenum, duodenum, starts with the D, all right? There's a few ways they say it, all right? The second part is usually going to be kind of, you can maybe see it here. It kind of comes back and then it falls to tubing that gets kind of like squished together up in this upper left-hand region. That is your jejunum. And then it'll continue, and then eventually down here in this back part, bottom here, this is going to be your ileum, and your ileum is going to then connect to the large intestines. Okay, so you have the duodenum or duodenum, the jejunum, and the ileum. In gastric bypass surgeries, they take part of the ileum and they connect it to the body of the stomach, and the goal is you don't need this. You don't need most of the small intestines anymore. And then people's foods will not be as absorbed, will not be as digested. And so you won't absorb as much, so you can lose weight, okay? People who get the gastric or the lat band, they put bands around the stomach so the rugae, so that expandability of the stomach can't happen. So food would potentially get to the fundus region faster, and the fundus region would start to make the hormones to tell your brain, stop eating. Okay? Now, inside the small intestines, there is going to be what's known as these permanent hills and valleys. So the hills and valleys and the folds here are stretchable. That's why they're known as rugae. In here, they are not stretchable. They are known as your Pilica circularis. And each Pilica circularis, if you look at this model, is full of simple columnar cells. And then these simple columnar cells, if we were to look at their heads, the exposed part, they are full of microvilli, which is like hair extensions. So they can interact with anything and everything in the lumen of the small intestines. Okay? There are still, if you look, going to be some of these indentation areas, right? And these indentation areas, like up here, are going to be glands. And these glands, because they're in the small intestines, are just intestinal glands. Okay? On the back of this model, they kind of show you, again, here's some of the glands from the stomach, and then here's some of the glands from the intestines. Okay? And again, they're still simple columnar cells, and they will make secretions, and those secretions will then join the food and the water and the stomach acid that's been neutralized and become part of the chyme that's in your small intestines. All right? Now, technically speaking, the duodenum, the first part of the small intestines, is going to, if you look at this, it's kind of going to be pushed back. It's going to be pushed closer to the kidneys and pushed closer a little bit like next to the spine. It is going to fall a little bit towards the back of your body. So it is going to be technically not in the abdominal pelvic cavity in the front part. It's going to be pushed to the back. So it is going to be what we call retroperitoneal. So the outside of this duodenum, the outside C shape, is going to be an adventitia and not a serosa. All right, so this is like one little part in the middle of the alimentary canal where it kind of pops backwards and it pops away from the bedding and from being wrapped in the bedding. And because it's an adventitia, it is going to allow some of the, again, capsule of the pancreas to kind of merge, and the pancreas is going to kind of, again, fill in the space that the C takes, and that's the head of the pancreas. And so they kind of stick to each other. If the visceral and the parietal peritoneum were between them, they would be able to move independent of each other, but they are kind of stuck together. Okay? All right, so that's the duodenum. When your duodenum pushes back in and becomes the jejunum, then it's back to a serosa, and then the entire jejunum and ileum are all serosa for their outermost layer. Okay, you're also back to 2 muscle layers, so I can try to make this, again, shorter, longer, shorter, longer, and then squeeze, 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 squeeze. So I have a longitudinal layer and a circular layer. Okay, and as the food goes through, if food's in this part, squeeze, 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 all right? The enteric nervous system is going to be kind of in charge of the stretch, the chemistry of what's going on, and reflexively telling the intestinal gland cells, make more stuff, or telling the smooth muscle cells, mix faster, mix more. And then the movement of the food from here to here to here, that's mostly the enteric nervous system, not your brain. Okay? All right. So that's kind of one of those exceptions about the duodenum. It's always a good test question. What is the outermost layer of the duodenum known as? It's known as a adventitia because it's retroperitoneal, not a serosa. Okay? We'll come back to the pancreas later. All right. Did I get everything? All right. So again, the front part of the small intestine, starting where the stomach ends, is the pyloric sphincter. The ileum is going to connect to the large intestines. That is going to be your iliocentral valve. Okay? So here's the small intestines. Again, it kind of shows, here's the C shape. That's the duodenum. Here's where it connects in, becomes the jejunum, becomes the ileum. And then where the ileum starts to, again, end and it goes into the large intestines, this is a valve. Why a valve and not a sphincter? Sphincters open and close easily. Valves are one-way doorways. So remember that the large intestines is full of bacteria that are your microbiome. Foreign entities that live inside of you, you utilize them to your advantage, but you keep them out by not letting them into the small intestines. Okay? All right, large intestines. You're going to have this little initial pouch is known as the cecum. Coming off the cecum is your appendix. Again, if someone's appendix burst, all of the bacteria that lives in the large intestines can now become part of your hypodermis. Get into your lymphatic system, get into your body, get into your organs, can get and cause you to die very painfully of sepsis. Okay, so that's part of the reason why we don't want our appendix to ever burst. This is the cecum. This where it starts to go up, it starts to go around, down, and then it has to get on midline. So it makes this little S shape. That is your colon. This segment of your colon that goes up is ascending. This segment that comes over from right to left is your transverse. This segment that goes down is your descending. And this segment that gets you from the left side of your body back to midline, so makes that S, is your sigmoid. Okay? The colon's job is to take the liquidy soup, that is your food that is left over, that's still suspended in water, and to dehydrate it. And as you dehydrate it, it becomes less soupy and more muddy, and then eventually poopy. If it gets too dry, it becomes rock hard, dried mud cakes, and it can impact or get stuck. So your colon's job is mostly water absorption, to get all this water in your system back and to leave just enough water that whatever is the muddy mess will slide out and not dry out and impact. Okay? Since most of you are going to be nurses, much of your life is going to be pee and poop of your patients. When you're giving your patients morphine, when you're giving your patients anything that's oxycodone, some type of heroin, opioid thing, one of the issues with those medicines, if you go and watch Train Spotting, you'll see more clearly, all right, is it is going to make you impact or dry out in the poop, and it's going to impact and stick and get really, really dry, okay? And then those people, you won't let them out of your care or leave the hospital if they can't poop, especially if they just had surgery and they're on their opioids, all right? And so we don't want them to basically become impacted, and then we have to manually go in and clean that out, okay? Or it comes out explosively and makes a huge mess that then you as the nurse have to go clean up. Again, go watch Train Spotting, Ewan McGregor. It was 1995, that movie. He's a heroin addict. And there's a scene where as a heroin addict, he hasn't pooped in a few days. And some of you have had kids, and sometimes they say breastfed babies, they poop once a week. But when they do poop, it is massive explosions. Yeah, that's what happens, okay? Again, as a nurse, you worry about pee and pooping. When you start to have people who have spinal cord injuries or they're bedridden and they might not be able to get to the toilet, or they don't any longer feel the sensation of poop accumulating in their rectum, you're going to have to go in and either manually, with gloves, of course, manually stimulate to try to, again, stick your finger in their poop hole, stretch it out a little bit, see if that'll get some peristalsis going, get it to move so it doesn't become impacted. Or you put your gloves on, you stick a suppository in there to chemically get things going to try to get the poop out. All right? Your life as a nurse is not going to be very glamorous. You're dealing with a lot of pee and poop. And for people who have spinal cord injuries, let's say like most of us who have been living a normal life, it's very humbling, and it's part of the reason many people have a hard time adjusting to that life as a spinal cord patient, when 3 times a day you have to get help from someone dignity-wise who has to cath you and massage your anus to get poop movement, on a regular basis, so you don't get impacted. All right? Again, most of the intestines is going to be a serosa. It's going to be that visceral peritoneal membrane. As you get underneath the bladder, as you get back on midline, as you get down really deep towards the pelvic floor, the rectum is going to then be the outermost layer back to an adventitia. So it can, again, it's underneath the peritoneum. All right. Okay. For the innermost layer, we still have simple columnar cells. All right. So if I get back again, my histology down here, I have simple columnar cells. I still have some intestinal crypts that can make and help me absorb water. I still have some, again, ability to create some molecules, secretions. Inside, I'm going to have a lot of bacteria. Again, your microflora. That's been like people donate their poop because in your poop is some of the bacteria that come out that live in your stomach. And again, for some people who have had massive antibiotics or they're, constantly sick, they try to harvest that microflora and they're going to try to, donate it to people to try to get their microflora up. Some of the microflora in here are also tied to your immune function. So there's a lot of fun research about studying poop and the bacteria in your body in the large intestines. Okay, so again, the mucosa layer, simple columnar, areolar connective tissue, that muscularis layer, submucosa. What is interesting here, see how it turns red? The muscle layer and the muscularis externa layer is going to, one of them, get really, really skinny. And that really, really skinny layer is part of why you see the taniacoa here, that line of muscle, and you don't necessarily see it elongated around the whole colon. Okay, and then between it and how the circular muscles work, you're going to have these little segments. Those are the haustra. Okay, this turn, let me get my orientation. The upper right turn, which is underneath the liver, is going to be your right flexure, your right colic flexure, or your hepatic flexure. The turn here is your left colic flexure or your splenic flexure because it's underneath your spleen. Okay. And then associated with the taniacoli, the muscle layer, are these little fatty appendices. Again, large numbers of adipocytes that kind of hang out and provide, again, fat and muscle fuel if they need them. Okay? All right. I'm kind of making a mess over here, so I'm not sure which sheet I'm on anymore. All right, now we're ready to go to, I think, the pancreas next. All right, and again, your pancreas, real simple. Here is the head, here is the tail. If people like the salivary glands, this is epithelial tissue. It goes through a lot of evolutions of reproduction. Your insulin, your glucagon, alpha and beta islet cells secrete into the blood supply. Your other cells are making secretions that are ending up in this tubing known as your pancreatic duct. Okay? Those secretions are going to be things like pancreatic amylase, pancreatic lipase. Then they're going to have their protein molecules you digest, chymotrypsinogen, trypsinogen, and when they get into the small intestines, they become trypsin, chymotrypsin, and they break down proteins. Pancreatic amylase helps you break down more complex carbohydrates to maltose. Pancreatic lipase helps you break down more fat from triglycerides to free fatty acids. Your intestinal enzymes that are going to come into play are going to be lactase, sucrase, maltase. So they are going to take the disaccharides and finish breaking them down to glucose, fructose, so you can absorb them. Again, people who are lactose intolerant, they don't make lactase in their intestinal glands, so they can't break down the disaccharide lactose unless they take lactase, like some of those lactase drugs, or they just avoid lactose-rich foods. You're also going to have some more, again, enzymes for protein digestion. You'll have intestinal lipase that helps break down fats. Okay, and again, most of that's going to be for your lecture part of your test. So make sure you kind of have maybe a flow chart. In the mouth, what are my enzymes and what do they break down? In my stomach, what are my enzymes? What do they break? The esophagus doesn't do any breakdown. In my large intestines, what comes from, in my small intestines, what comes from the intestines, what comes from the pancreas, what comes from the liver, all right? And what do they do? So which break down proteins, which break down carbohydrates, which break down fats. And then by the large intestines, any enzymes are from bacteria, all right, that do the breakdown, and you're just absorbing whatever you can, continue to absorb that the bacteria, technically foreign entities, have enzymes to break down. All right, the tail of the pancreas is over here. For cancer purposes, Patrick Swayze, Alex Trebek, if cancers start over here, they can kind of grow and expand and get really, really complex, really, really dangerous, and then start to metastasize before we even realize they're around. Versus if pancreatic cancers start over here, they might clog the gallbladder, the bile duct, the pancreatic duct, and cause digestion issues because you don't get the enzymes. So then you have food poopy issues. You know, when you eat, you have a lot of stomach pain, belly pain. So pancreatic cancers that are from here are actually cancers that we might catch sooner and have better odds of beating than pancreatic cancers here. Most of the time when we find pancreatic cancers, we find them stage 4. They're very, very advanced. They don't respond to drugs, chemo drugs. It's hard to radiate this because you still need it and you still need the enzymes from it for hormones from it. So you can't live without your pancreas. So that's part of the reason why most people die. It's a 95% death rate, I think, for 5 years after living after you find out you have pancreatic cancer. Good news is my sister is going to hit 5 years in July. Her cancer was blocking her bile duct, and she kept having, in a 40-year-old woman, all these digestive issues, and they kept saying it's your gallbladder. They took her gallbladder out, and they found the cancer when they found the gallbladder issue. And it wasn't the gallbladder. It was pancreatic cancer. So she is one of those 5% of people that is actually going to make it 5 years since her pancreatic cancer diagnosis. So we're partying this summer. That's the point of that story. All right, liver and the gallbladder. And look, somebody even has the numbers on here. So remember, here's your liver. This is the right lobe. This is the left lobe. So when you turn it under, this is the right lobe. This is the left lobe. So this would be, what is number 26? The left lobe. Okay. This guy here looks like it makes a little square. So what is a square quad? The quadrate lobe. And then this little guy, it looks kind of like he's making a tail. And I think the picture in the book's really good. That's the caudate lobe. Right? You have the round ligament and the falciform ligament. And at one point, they were a blood vessel. So those are the landmarks there. This is your hepatic portal vein. So all the blood vessels from your stomach, all the blood vessels from the small intestines, all the blood vessels from the large intestines, and the lymphatic vessels are going to the liver. So 2/3 of the liver, remember, the blood is coming from veins, bringing the liver to show the liver how much carbohydrates I got, how much fat I brought in, how much protein I have. So the liver can try to figure out, okay, we don't have enough alanine proteins, I got to make that. I don't have enough glycine proteins, I got to make that. I didn't get enough cholesterol, I need to make some because I need estrogen, testosterone, and progesterone hormones, you know. So the liver needs to see everything that you ate so it can try to figure out what you missed, what are you not getting, so it can try to make it, if it can. Okay, and then here's your gallbladder. All right, for your gallbladder, the liver is going to take, again, bilirubin. Remember old bilirubin from your red blood cells? It's going to take some calcium, it's going to take some sodium, it's going to take some chloride, some potassium, and water will follow, and it's going to make this secretion that's known as bile. And it gets its name bile because it's rich in bilirubin. All right, and so it is going to eventually, all the cells from the right lobe and the left lobe are going to send their bile through these right and left bile ducts. All right, and then where's my little cheat sheet? And then the bile ducts will combine to form the common hepatic duct. And then the common hepatic duct can go back and forth into the gallbladder. That's through the I'm blanking. Cystic duct. And then the cystic duct, and again, that common hepatic duct are going to join together, and then eventually that duct will come down. Oh, it's over on this side. Down the head of the pancreas. That's known as the common bile duct. And that common bile duct is going to join with the major pancreatic duct, and they are going to push in secretions to the small intestines in the duodenum through the common doorway. Okay? And that common doorway, if I remember correctly, is your hepatopancreatic sphincter. right? And the little enlargement of the area in front of it is known as the duodenal ampullus. Remember, an ampulla, it's kind of like a sinus, it kind of an enlarged tube. So the common bile duct will kind of have a little bit of an enlargement right there, standing right behind the door so the bile can kind of accumulate. The bile is going to be mixed with pancreatic secretions, and you will squirt those into the intestines as food's coming in. And so it's going to add bile to help emulsify fat. It's going to add, again, some liquid. It's going to add pancreatic amylase, pancreatic lipase, chymotrypsinogen, trypsinogen, some of those nasty protein breaking enzymes all in here. Okay. Now this shows that some people have another duct from the pancreas that goes a little superior, a little bit higher up. That's known as your accessory pancreatic duct. And if you read in your book, it says like a third of people actually don't have that. All right. So a third of people, the only way for things to get in is through this one duct with the bile. Okay. All right. I think I covered everything. Anything I missed, you will hopefully be able to find it between what's listed in your lab manual and what's listed in the pictures in your book. But hopefully that gave everybody a little bit of what to expect, a little bit lecture content, a little bit of anatomy content. So I am going to stop the recording.